Hello, my name is Ruth Olaya Rojas, and today I'm going to talk about approach to catheter ablation for persistent atrial fibrillation. First, the definition. Atrial fibrillation, AFib, is a type of heart disorder marked by an irregular or rapid heartbeat. Persistent AFib is one of three main types of the condition. In persistent AFib, the symptoms last longer than 7 days, and heart's rhythm is unable to regulate itself anymore. The other two main types of AFib are paroxysmal AFib, in which symptoms come and go, and permanent AFib, in which symptoms last for more than a year. AFib is a progressive disease. This means that many people first develop paroxysmal AFib with symptoms that come and go.
Your heart is a muscle that pumps blood around your body. It's made up of 4 chambers, 2 at the top called the atria, and 2 at the bottom called the ventricles. Your sinus node sends out electrical impulses. Atrial fibrillation, or AF for short, is when other areas of the atria send out electrical impulses too. These irregular impulses cause the atria to twitch. When this happens, blood isn't pumped out effectively, which could cause a blood clot to form. If this clot travels to your brain, it can lead to a stroke. When your heart isn't pumping blood properly, it can lead to symptoms such as tiredness, dizziness, or feeling faint, shortness of breath, or palpitations. How AF affects you will determine the treatment you need. Some people with AF, like Harry, only have mild symptoms or may not experience any symptoms at all. Harry noticed something might not be right when he felt his pulse was irregular and sometimes fast. Harry was at higher risk of AF because of his age and high blood pressure. Those with a heart valve problem are also at a high risk. It's important that Harry avoids further strain on his heart by getting treatment for his AF to reduce his risk of stroke or heart failure. The best course of treatment for Harry was anticoagulant medicine called warfarin to reduce his risk of having a stroke, followed by a cardioversion to try and restore his normal heart rhythm. However, some people may need other treatment, such as ablation or other suitable medication. Thanks to his treatment, Harry's AF is manageable and he can return to work and exercise when he feels ready. For more information on living with atrial fibrillation, visit bhf.org.uk/AFib. BHF. Beat heartbreak forever.
Applications in medicine. Catheter ablation is a way to treat irregular heartbeats or arrhythmias like atrial fibrillation, atrial flutter, or supraventricular tachycardia. It destroys the tissue that's causing your heartbeat to get off course. This creates scar tissue inside your heart. This scarred tissue is a good thing, and it will help your heartbeat stay in rhythm.
Hi Tricia, how are you?
For Maggie Burke, an electrical problem in the heart called atrial fibrillation became debilitating.
It scared me at first, of course. I even called 911, but it was irregular and fast. And after several tests, they said it was just what they call lone AFib. It's atrial fibrillation.
They didn't know about her, apparently.
Burke is a nurse at Barnes Jewish Hospital. The condition made being on her feet for long periods difficult.
When I'm at work, I have to walk a lot. I couldn't do that. I'd notice I'd get a little short of breath, never dizzy, but it really wore me out. And I think that's the biggest thing I wanted to tell other people. It wore me out.
Atrial fibrillation, or AFib, affects around 3 million people. For some, there are few symptoms, but many complain of palpitations, fainting, shortness of breath, or chest pain.
It debilitated me, and I don't think I realized until after I had the ablation how bad I was.
It's particularly debilitating for people who are used to an active lifestyle, who like to exercise or have a busy job, anything that's physically demanding.
Most patients are treated with medications. Another option is a surgical procedure invented at Barnes-Jewish Hospital called MAZE. However, a growing number of people now receive something called catheter ablation.
Since the early 90s, the hope was that we could duplicate many aspects of Maze surgery with catheter ablation. Catheter ablation is a way that we can minimally invasively enter the heart and create scar tissue through electrical current.
Dr. Faddis and his colleagues at Barnes-Jewish Hospital and Washington University School of Medicine have taken this treatment to the next level, using a system developed at Barnes-Jewish called stereotaxis.
The system is controlled by a computer, and there's three-dimensional mapping that goes on, and with that precision we're able to see the catheter tip in real time and move it around with millimeter precision. So I think the promise of that is very exciting, and we think it's going to be revolutionary for the continued development of the catheter ablation for AFib.
The procedure is non-surgical and allows for quick recovery.
What's he doing?
In Burke's case, she was discharged from the hospital by noon the next day.
I felt like a new person. I mean, I just couldn't believe how good I felt within probably 48 hours. And again, I didn't want to admit that I was as bad as I was. Friends knew, friends started to notice, people I worked with would notice, you just seem exhausted. And now I'm back to, I'm back to the old Maggie.
For more information about atrial fibrillation or catheter ablation, visit www.barnesjewish.org.
Ablation is generally not the first treatment option. Ablation is a treatment option for people who have tried medications to treat an arrhythmia without success, have had serious side effects with medicines to treat arrhythmias, have certain types of arrhythmias that respond well to ablation, such as Wolff-Parkinson-White syndrome and supraventricular tachycardia, and high risk of complications with their arrhythmias, for example, cardiac arrest.
Discuss ablation procedure for AFib. In this video, we will discuss ablation procedure for AFib. Who has the best results with AFib ablation and who has the worst results? Ablation for AFib is a procedure done in the hospital where a doctor threads a thin catheter into the heart and creates scars in the heart tissue with either heat or cold to alter the electrical signals in the heart. The typical AFib ablation creates scars around the pulmonary veins in the left atrium. This is called the pulmonary vein isolation technique, but also can create other areas of scar where there are electrical signals that may be causing AFib. The best candidates for AFib ablation is someone with AFib that comes and goes, which is called paroxysmal AFib, and has symptoms when they are in AFib. They may have already tried medication which didn't work for them, either because it didn't help with the AFib or caused side effects, although some people may choose ablation without trying the medications first. AFib ablation may also be a good option for people with long-standing persistent AFib. That's people that have AFib that lasts more than 7 days, who continue to have symptoms and medications aren't helping. For younger people with AFib, even if they don't have symptoms, and then lastly for those with heart failure and reduced ejection fraction, some studies show that those individuals live longer after ablation, improve their ejection fraction, and have fewer hospitalizations. If those are the patients that do best with AFib ablation, then who are the patients who are not good candidates for ablation? People who should not undergo AFib ablation include patients with no symptoms, a preserved ejection fraction, and adequate rate control, older individuals who are too frail to safely undergo the procedure, patients with left atrial appendage thrombus or a blood clot in the heart, or individuals who cannot receive blood thinners around the time of the procedure. People with long-standing persistent atrial fibrillation, that's atrial fibrillation that has lasted over a year, have the lowest odds of success with AFib ablation. They should have a thoughtful discussion with their doctor to understand the pros and cons of such a procedure. And if you would like further information about ablation for AFib, take a look at our video on the potential complications of AFib ablation. Thanks for watching, and if you want to learn how to take charge of your AFib, join our AFib solution community by clicking the link below. And if you like this video, hit the like button below, share it with your friends, and be sure to hit the bell and subscribe.
Pros and cons. Pros, first we have a higher success rate. On average, ablation has a 70 to 80% success rate. Those who are young, whose AFib is intermittent, and who have no underlying heart disease can have success rates as high as 95%. Second, low risk of complications. Fewer than 5% of patients develop any problems. Rarely, the use of the catheters can damage your blood vessels and cause bleeding or infection. The risk of more serious complications like stroke and heart failure is less than 1%. And third, quick recovery. The procedure takes about 2 to 4 hours, and patients can be discharged the same day or after an overnight stay. It causes little or no discomfort, and it's done under mild sedation with local anesthesia. Cons. First, the repeat procedures. For 20 to 30% of patients, the first ablation doesn't work and they have to go back for another, and that's because some abnormal tissue might have been missed or burned tissue held and recovered function. Second, ablation doesn't work for everybody. Catheter ablation is less successful for persistent atrial fibrillation than for a paroxysmal atrial fibrillation. Gildiness suggests that adjuvant substrate modifications, in addition to pulmonary vein isolation, is required in persistent atrial fibrillation. Third, sometimes medication is still needed. It can take 1 to 3 months for scars to fully form on the sites that were ablated and to know if the procedure worked. During that time, a patient may still experience palpitations and may even be prescribed antiarrhythmic medications. Fourth, the arrhythmias. New arrhythmias. Ablations can sometimes even cause new arrhythmias when an area of scar is created at the chamber of the heart. That scar can be the site of a new abnormal rhythm. And the last one is blood thinners. The use of blood thinners can decrease the risk of a stroke even if you weren't on blood thinners before.
About 4 years ago, I started experiencing a lot of congestion in my lungs, and I'm a veteran, so I use some of the VA health services, and one of the nurses there picked up this irregular heartbeat. I didn't actually realize that I was pretty sick, and my heart was operating at less than 30% efficiency.
So Mr. Siegel came to us and he was in atrial fibrillation. So atrial fibrillation is an irregular heartbeat. In atrial fibrillation, the top chambers, the atrium, start beating very chaotically and erratically. This causes the heart to lose its ability to function optimally. Consequently, patients feel short of breath, fatigue, tired, they have palpitations. If it's untreated, blood clots can form in the heart, and these blood clots can cause strokes. Up to 25% of all strokes in this country are caused by atrial fibrillation. But however, in terms of preventing atrial fibrillation and stopping it from recurring, there are medications we can use which are called rhythm control drugs. But they don't work. They don't even work 50% of the time. There's a procedure that's called catheter ablation. That's where we thread a catheter up through the veins into the heart, and we try to target the triggers where the atrial fibrillation is starting. The University of Miami U Health System was part of Cabana, which was a multi-center landmark study comparing catheter ablation with medications in patients with atrial fibrillation. This was the largest atrial fibrillation study in quite some time, and they picked the best centers around the world, and we were fortunate to be included in that group. In this study, 2,200 patients were randomized to either receive catheter ablation or medication.
My participation would be a contribution to this whole question of what is the best way to address the type of condition that I had.
In the Cabana study, it showed that in terms of reduction of atrial fibrillation and prevention of atrial fibrillation, that ablation definitely outperformed medication. It was at least 40% better in terms of prevention of atrial fibrillation.
It was a very, very uplifting feeling that I still had some life rewards ahead of me, and that has been, in fact, the case for me.
With the results of the Cabana study, we can look at patients more carefully, and we can discuss the pros and cons of undergoing a catheter ablation.
Issue applied in Ecuador. In Ecuador, the pathology generated 3,701 hospitalizations in 2018. According to INEC data, there were 1,419 cases due to atrial fibrillation. The cryoablation procedure is performed at the Luis Bernaza Hospital of the Guayaquil Charity Board. This medical home applied cryoablation for the first time in its facilities at the end of November and has more than 10 operations. 2 other clinics in Quito and Cuenca will also do it soon. Luis Jhon, head of the arrhythmia unit, comments, "The greatest benefit of this technique lies in the fact that the treatment is carried out by freezing in a single energy impact and in a faster and more efficient way. The efficiency for cold and heat is the same, but the first with a lesser risk. It's a pride to receive the first cryoablation equipment in the country, which marks a historic event for the hospital, where it will have a massive impact due to the high number of patients requiring this procedure," the specialist highlighted. Finally, the conclusion is that ablation techniques for the treatment of persistent atrial fibrillation must account for the pathophysiology differences between persistent and paroxysmal atrial fibrillation, including a greater importance of non-PV tissue. Catheter ablation approaches that have a limited role at this time for ablation of persistent atrial fibrillation include targeting of focal triggers, segmental ostial isolation, and ablation of vagal LA inputs. Approaches that do appear to have a role include wide area circumferential PV antral isolation, ablation of CFAE sites, and linear atrial lesions. A stepwise approach that involves the use of these latter 3 methods appears to be promising. Thank you so much.